Good afternoon, ladies and gentlemen who have joined us on this Dr. Fundi platform via multiple social media platforms, Facebook, YouTube, Twitter, Instagram, and also the Dr. Fundi website. Welcome to our broadcast this afternoon. This month of September is actually known as the month where there is awareness that's being created throughout the country about various health conditions. One of those is cervical cancer awareness. As you know, last week we dealt with awareness relating to people who are living with albinism. Today, our focus is just on cervical cancer. So I've got two guests, very powerful ladies who are my guests today. I'm going to read their profiles, so you must bear with me because they are long profiles for both of them. But it's important that we take them through, so that you know why they are here. They have spent a lot of time behind the desk. They've burnt the midnight oil so that we can be a much more healthier nation. And so I will start with Dr. Nondumiso Ngxola. All right. Dr. Nondumiso Ngxola, Niem Kontwana. She is a qualified ONG specialist, that is obstetrician and gynecologist. She's a qualified ONG specialist, born in Cape Town some years ago, but grew up in Umtata, where she matriculated. And then after matriculating in Umtata, she went to Walter Sisulu University, where she trained as a medical doctor, qualified in 2005. She did her internship and community service at the Nelson Mandela Academic Hospital in Umtata. She became a medical officer, and then in 2010, she actually decided to go and study to be a specialist, ONG specialist. All right, so she was accepted as a registrar at Frere Hospital, where she underwent her training. And in 2015, she became an ONG specialist, continued to work there as an ONG specialist. And then in 2017, June, she decided, no, man, I want to do more. So she went to Grooteskier in Cape Town and worked there as a urogynecologist in the ONG department. But then a few months later, she got a scholarship from the Discovery Foundation to subspecialize in gynae oncology. And so from March 2018 up until December last year, she has been training in gynae oncology, and she was due to write her exams early this year. She will tell us whether she wrote them or maybe COVID messed her up in terms of the preparations and everything. But since May, she's been back at Frere, where she's working as an ONG specialist. And she's got a special interest in the area of CA cervix. And so that's why she's so relevant to be our guest today. Dr. Nondumiso Ngxola, welcome.
Thank you, Dr. Fundi. Thank you for that warm welcome, and greetings to our listeners or viewers at home.
Lovely, lovely. Now I am going to also introduce Dr. Zuki Jafta. Now, yes, she's got a long profile, but it's important. Dr. Zuki Jafta Madasa, she is a qualified radiation oncologist. She started as a doctor, by being an intern at Frere Hospital, year 2000. And then she did ComServe at Makiwane, Cecilia Makiwane in Tanzania in East London. And then worked as a medical officer in the ONG department, obstetric and gynecologist. And then after that, she decided to join a research unit, which was called the Effective Care Research Unit, as a research manager. So she spent 2 years there, coordinating training on behalf of the World Health Organization, training in maternal and child health, disseminating critical information and making sure that she builds capacity in our province, home province of the Eastern Cape. She moved from there and became a part-time lecturer for nursing students at University of Fort Hare Department of Health Sciences. Later, she became a project manager to set up an ARV unit, in the Eastern Cape for both Cecilia Makiwane Hospital and FRE. 2011, she decided, enough, I need to go and study further. So she became a registrar doing radiation oncology at Walter Sisulu University, doing work based at Cecilia Makiwane and also spending time at Groote Schuur Hospital in Cape Town. So she had a leg in the Eastern Cape, another leg in the Western Cape, trying to make sure that she gets this knowledge. And so she then, qualified as a radiation oncologist. She's going to tell us what is a radiation oncologist. For people like us who left school quite early, she'll tell us what that is. Right, so 2016, 2017, she was a consultant in radiation oncology at FRE. And then 2017, she got an opportunity to set up specialist oncologist, unit at Nelson Mandela Academic Hospital, where she's responsible, or she's been responsible for decentralized Mandela Cancer Center services for the Nelson Mandela Academic Hospital programs. She facilitates, extension of radiotherapy services for the hospital. She also provides, oncology services under the Vet Health Consortium for KZN Oncology in Addington Hospital. She also supports a hospital that's in Mpumalanga, Rob Ferreira Hospital Oncology Unit, which she helped to set up from scratch, facilitating provision of chemotherapy services, data management, collection, and also liaising with hospital management. She is also very involved in matters of advocacy and community outreach via her Beat Cancer Foundation. She's a founder and director of that Beat Cancer Foundation that is, aimed at increasing access to information about cancer, care about cancer, and all issues relating to cancers, really. She even wrote a booklet in 2017 that is meant to make the information about cancers accessible to people who did not go to medical school. She's been involved in a lot of scientific research papers since 2002. She has conducted a lot of workshops. And on top of everything that she studied, she also has got a master's in public health. So this is a lady who just doesn't get tired of studying. So, Dr. Jafta, welcome to the Dr. Fundi channel.
Thank you. Welcome. Thank you for the welcome, Dr. Fundi, and to the viewers at home.
Yes, lovely, lovely, lovely. Now, I've welcomed both of you, but I think it would be better if each one of you, just a minute, just say, for example, Dr. Jafta, what is a radiation oncologist, and what made you choose that? And I'm going to ask the same question to Sis Nondumiso, Dr. Nondumiso.
Yes, thank you very much. A radiation oncologist is a medical doctor that decided to go and specialize in treating cancer.
Yeah.
And I would just summarize it as that: to treat cancer using X-ray treatment, like high energy X-rays, in trying to treat and direct those rays into treating cancer.
Yes.
The radiation oncologist, for what I've done, we actually are called clinical radiation oncologists because we're using also chemotherapy as well as radiation to treat cancer. We are different from medical oncologists that only focuses on chemo. And that is exactly what happens. So we target specifically ways and means of treating cancer using both modalities and more.
Yes.
So the radiation oncologist is that in a nutshell, and works in a multidisciplinary team with the surgeons as surgeons, and we also work with the gynaes. We work with also with the radiotherapists. The team includes the physicists, those that are doing the machine.
Yes, lovely, lovely. Thank you very much. And so what attracted you to that though?
Well, what had attracted me were various things. One, you know, we come from the rural areas where people present with funny and diseases that nobody knows. And, you know, it keeps you thinking, what was that? You know, first time we see tumors that big in a rural area. And anyone who knows that you're a doctor, they like, please come and see this. And there's expectation that you know, and the treatment. However, I worked a lot in the HIV unit where we're seeing a lot and treating a lot of Kaposi sarcomas. Yes. And it intrigued me to see that for us to treat Kaposi sarcoma, which is a tumor caused by HIV, we were busy giving ARVs. And the interesting part was we also need to give chemotherapy as treatment to Kaposi. So I was asking myself, what is this chemotherapy? And 1 minute we're giving antiretrovirus to boost the immunity. The chemotherapy we are giving is actually decreasing the immunity. So I was intrigued, like how do I balance the two? If I'm making the person weaken the system, and this side I'm trying to give something to strengthen the system. That's one. Secondly, my father-in-law presented with prostate cancer. Yes. And was under my care at my house. And for him, it was an easy go. And most of the people that was in the ward, they were more sicker than him. And he used to joke about it, that we need to tell more people about this. Yes. So, you know, you get inspiration around you. You get inspiration during your treatment, your training. And it fascinated me that, you know, this field is very interesting. It's nothing that we did in undergraduate. Yes. And I was striving to hear more and take the challenge.
So it was really driven by you identifying the need, you know, on the ground, seeing that, you know, in the rural Eastern Cape where you were practicing, there weren't many of people with that kind of skill. And so you thought, well, let me go and get this knowledge so that I can come back and be a savior for the province. Would I be right?
Thank you.
Okay, thank you. Let me go to Sis Nondumiso. Dr. Ndumi. Right, you are a qualified ONG specialist, and you are 5'2", being a gynae oncologist. I know you are sensitive about that. You didn't want to mention that because papers are not yet there. But you finished your training as a gynae oncologist. All you need to do now is to actually pass those exams, which I'm sure you are going to pass them. So I want you to tell me two things. The attraction to ONG as a specialty, you know, and also gynae, you know, specializing in cancers that affect women. You know, what is the attraction there?
Thank you, Dr. Fundi. For me, what attracted me in ONG is realizing that I love working with women, and but the whole interest in ONG actually started as wanting to be a gynae oncologist. Yeah. So it's been a while. Okay. So hopefully by next year that dream will be realized. So when I worked in Amtata, we used to have patients that would come from Amtata to East London for their cancer treatment in Gynae. And I mean, some of them, it will be someone coming all the way from Bizana to sleep over somewhere, then get to Amtata, and then come to East London. Yes. So I remember we had one lady, I'll never forget her. She used to actually be an escort for these patients, and she also herself had a cancer. So in our discussion with then the head of department, Professor Buka, talking about this and the need for gyno-oncology services, especially in our area, then I thought that, you know, as much as I love working with women, there's always this part that has been, obstetrics has been that part that I like it, but I feel like I can't do it for the rest of my life. But if I can do oncology, then I'll get to do what I love doing, which is working with women. Yeah. So when we had this discussion, he said, but you can do ObsGynae, but then continue doing gyno-oncology. Yeah. And then after that, I met few people who told me that you can actually do this. And then at that time, I didn't know anyone who was a gyno-oncologist. So it started then. I started specializing. And then when I moved to East London, one of the head of department of Groote Schuur Hospital, Department of ObsGynae, Professor Lynn Denny, visited Frere Hospital, and she was a gyno-oncologist. So I remember my first meeting with her, I didn't leave her side. I was asking her so many questions because this is what I've always wanted. Yeah. And then it started like that. And when I qualified as an obstetrician and gynecologist, I did feel discouraged and thinking, do I want to continue doing this? And when I was at Frere, I also started an outreach, going to Butterworth Hospital, running a colposcopy clinic there. Yeah. And also realizing that there are a lot of patients with early cervical cancer that can be treated by surgery, but are not receiving that treatment because there's no one with that skill in the area. And at that time, we didn't have any gyno-oncologist. Yeah. So there was an arrangement with Frere Hospital that doctors would come from Groote Schuur and Tygerberg Hospital to come and operate on these patients. And I facilitated, or I used to be in charge of that. And also because my then head of department knew I had an interest in gyno-oncology. So when they come, I'll get an opportunity to operate with them and work with them. And then I then decided that I would want to do this, but there were so many hurdles, but eventually, initially I wanted the Eastern Cape to sponsor me to go to Cape Town to train, but they couldn't do that. So I had to resign and take up a post at Groote Schuur, and then I worked in ObsGynae for a short while. And then after that, with the help of Professor Lynn Denny and Dr. Nomonde Mbatano were my mentors, I then applied for a Discovery Scholarship. And then...
you were lucky.
Yes, and then I got that, and I managed to train in gyno-oncology. Yeah. And yes, I should have written my exam this year, but we can blame it on the COVID. So next year I'll be writing my gyno-oncology exam, and I'll be a qualified gyno-oncologist.
Lovely, 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 Doc. All right, so at least you guys have explained what made you choose these, subspecialties, or specialties that are actually quite rare amongst, people of our color. More so in rural provinces. What's interesting in your case? Can you please what's interesting in your case, in fact, in both of your cases, is the fact that you went and got the knowledge. You went and got the knowledge, and the very province is now benefiting from skills that you went and got, from another province, and maybe. It's a lesson that there needs to be more investment in the scarce skills because people who come from there are likely to actually, get there, and do the work in terms of what is needed. All right. I think with that background, we are now okay. I'm just going to ask a question to Dr. Zuki, and then we'll spend a bit of time with Dr. Ngxola, because remember the topic is around CA cervix, and most of the early part of our discussion is going to revolve around Dr. Ngxola, and then at a certain point, I'll come back to Dr. Zuki. But Dr. Zuki, when we look at the issue of cancer in the country, all right, in South Africa, cancers are included as part of the non-communicable diseases in the country, we read and hear that the numbers are growing, year on year. If you look at that broad group of non-communicable diseases, we hear that they are responsible for more than half of the deaths annually. All right, that's what we hear. And within that group are the cancers. What do you think is driving the apparent rise in cancers, in our country?
Thank you for the question. Yes, we have lessons that are learned globally, and highlights that in South Africa we highlight the incidences from a lot of states.
Yes.
So if you look at the Global Can stats in 2018, it does mention that even worldwide, cancer is it's a public health concern. It's the cause of death globally. And the different causes of cancer, as much as they differ per country, you will find that we have about breast, cervical, lung, prostate, and colon cancers.
Yes.
If you look at that, when you try to analyze what is causing and driving those, there are several reasons which are specific to certain types of cancers. And if you look in the South African profile, you'll find that we have certain factors that are driving it. But in general, what we've seen or learned is that we have genetic causes that take about 10% as causes for cancer. The heredity patterns, they are more like 10% of that. And if you look into the 90%, there are different causes that talk to the 90%. One, the big one is the lifestyle. We've seen about lifestyle, people are, and then under lifestyle, you've got diet, the inactivity, issues of inactivity are highlighted. And again, I won't go into detail which cancers are highlighting each one. I'm just going to be broad. And then we'll talk about the specifics for cervical later on.
Yes.
However, if you look at the 90%, it looks into lifestyle, activity, inactivity. We're looking at the smoking. We are looking at smoking prevalence. And in smoking, you need to be smoking for 30 to 40 years. And the prevalence of that causes a lot of cancers. And if you stop smoking, and it's only less than 10 years smoking, your risk is still high. You need to stop for more than about 20 years. And smoking, remember, you've got primary smoking, you've got secondary smoking. So the second smoke, someone mustn't smoke in the house because you are equally at risk of having cancers. Having said that, we're starting to see a new kind of cancer in lung where even non-smokers are beginning to have lung cancer. And it's a different route altogether. We're looking at issues of genetics and even different factors.
Yeah.
We're looking at the area of heredity. I think that was a 10%, which I won't delve into. And remember, with the genetics before, there is also mutation of genes.
Yes.
And the heredity, you have a link between your breast and your cervical cancer because there is sharing of some genetic mutations, just overall. So someone with breast cancer, you must check on the ovary. Someone with ovary, you must check the risk of breast, something like that. Then you look into different problems like viruses. Viruses cause cancers, and you can highlight them. I will list them for you. One is HPV virus, which is the human papilloma. We're going to talk about it. It causes a lot of cancers of the head and neck, even the cervical cancer we're talking about, and the anal cancers. We talk HIV. HIV makes you susceptible to Kaposi sarcoma for the skin. We're talking Epstein-Barr virus. There's a lot of nasopharynx tumor behind the nose. We know about that one. So there's a lot in the hepatitis C and the hepatitis B, anything to do with the liver. So we have viruses that can be oncogenics, which is they can cause changes in normal cells to become cancerous cells. In an occupational setting, you've got occupational exposure issues where you have tar. You know, people must be wary of the protective clothing because tar, asbestosis causing mesothelioma in the lungs. We've got a lot of those problems. And we always say, even if you're working in the salon, you must always put gloves because the chemicals you may not feel anything, but the chemicals that are there, they do make long-term problems. Because what you're dealing with is that a normal cell stop growing the way it's supposed to grow because of these influences of factors. So what happens is the signals in the normal cell that is supposed to be there, they stop working. And the normal cell doesn't get the signal to stop growing. So it actually starts growing, it doesn't listen, it actually doesn't stop, you know, because remember with the normal cell, as it grows, at some point it must die, and there's a programmed cell death. So there's a point where the cell cycle, they divide, and then eventually they must die. But when it's cancerous, it doesn't listen to all those signals, and you get prolonged growth, and you get masses and tumors. So now, all I've just mentioned to you are more irritants that actually enable that process of normal cell development to be irritated at some point, and it causes. And then alcohol is mentioned a lot with the head and neck cancers. And all you do is really in that aspect, it's susceptible to many of those cancers. You look into bladder cancer, and we always talk about children must not go and swim in those dams, you know, in our villages, because, you know, a 9-year-old child will be peeing blood, and you wonder what's going on. And they get some time of a bladder cancer because of a bacteria that they swallow there in that dirty water. So you begin to look broader as to where are the actual problems in this scenario. So you find that they are wide, and not all cancers are known. You know, the causes are known. So you have a component where there are unknown factors, but in most of them, they are sort of grouped in many ways.
Yeah. All right. No. So basically, what you were doing is to just give us a sense of what are the drivers of the seeming, increase in the prevalence of cancers in general. Yes, not that.
Sorry, I forgot the diet.
Yeah. All right.
The diet.
Yes.
So the diet mainly is the high-fat diet and the low-fiber diet. It's been seen in many studies that it does cause, susceptible to cancer because of influencing some estrogen hormonal imbalances. I won't go into detail how, but there is peripheral conversion of fat into estrogen, and then it makes more estrogen, and your body cannot deal with that. Okay. And you get a lot of estrogen driven cancers.
Lovely, lovely. All right. Now that just, sets out the broad, picture. Now I want us to zoom into the topic of the day, which is now cervical cancer. So I'm going to ask Dr. Nondumiso to now help us through. Dr. Ndumi, you are an ONG specialist, right? Can you just help us to understand this cancer called cervical cancer? For those people who are not trained medically, what is cervical cancer? Which part of the body are we talking about? Somebody else may hear, when we talk about the neck, we say cervical, so are we talking about a cancer that happens on the neck, or are we talking about a cancer that is elsewhere in the body? So I don't want to assume anything. So yeah, just help us to understand what is cervical cancer.
Thanks, Dr. Fundi. So cervical cancer is a cancer that grows on the cervix. So the cervix is the lowermost part of the uterus. It's the part of the uterus that opens into the vagina. Yeah. And on the cervix, we've got squamous cells that lines the outer part of the cervix, and another different types of cell from the inside. And these cells, maybe I shouldn't give those details, but then these cells, sorry?
Go ahead.
Okay, so there is a certain area on the cervix that becomes a target to this HPV virus that Zuki was referring to. So in HPV virus, there are different subtypes of HPV virus. There are viruses that cause cancer, and other viruses cause cervical cancer, and then the other viruses still in the female genital tract, they cause other abnormalities or other benign conditions like genital warts. Those are those cauliflower looking like growths that would grow on the vulva, vagina. Even in males, you do get genital warts. Yeah. So this group of viruses, the HPV viruses, they are sexually transmitted viruses. Yeah. And they can be...
Sorry, there's somebody, I've muted. I've muted that person, yeah.
Okay, so this HPV is a sexually transmitted virus. Condom use does prevent its transmission, but only at about 60%. Yeah. So as I say, it's sexually transmitted. It's more of a skin-to-skin transmission. So just any sexual contact will cause transmission of HPV. Yes. So you've got, in this HPV, you've got the high-risk types of HPV. And those high-risk types of HPV are responsible for cervical cancer. Yeah. So what happens is that these high-risk HPV, when they are on the cervix, there's a certain area, we call it the transformation zone. So if they infect that area for a very long time, so we have a persistent infection with HPV on the cervix, it causes cells of the cervix to change and they become dysplastic. Yeah. And those changes, they are usually minor changes and they progress to major changes. And then if those major changes are not treated, after some time they become cancer. Yes. So those minor and major changes, it's what the pap smear picks up. When someone goes and have the pap smear done, it will give a report that there's a low cell, which is a and also or high cell, according to what the patient has. So those are the changes I'm talking about. So if you have these high-grade lesions, the high cell, if they are left untreated, after some time, they become cancer. Yeah. And the rate at which they become cancer differs. They can take up to 10 years, but it's also been noticed that in HIV-positive women, this progression to cancer is quite faster than in HIV-negative patients. Yeah. And therefore, that also then affects the way how we treat these different groups of women.
Thank you. All right. So just to stop you there, Doc. So, you know, I want us to go with our people here. All right. So you are saying the main cause for CA cervix or cervical cancer is the infection by certain, you know, HPV germs. All right. Yes. Obviously, there's many, you know, subtypes or whatever of the HPV, but there are those that are actually, you know, the ones that do cause the damage, you know, on the cervix, right? Yes. So if we look at, you know, all CA cervix patients, what percentage would you say is actually caused by HPV? You know, would you say 100% of these cervical cancers are related to HPV infections, or would you say, you know, it's a certain percentage, but not all of them? So I just want to consolidate that information.
So there are two different cell types that you get of these cancers. You have squamous cells, yes, and you've got adenocarcinomas. And almost all of the squamous cell carcinomas are due to HPV virus. And there are two HPV subtypes, 16 and 18, and they're actually responsible for about 70%, 71% of these cancers. And the rest is due to the other high-risk subtypes.
Lovely, lovely, lovely. Because I heard something about number 6 and number 11, which can also cause the anal, you know,
the genital warts, yes.
Yes, as well.
And anal cancer.
All right, we're gonna come back to this thing. All right, so basically, if this virus or this group of viruses are actually responsible for so many or such a high percentage of cervical cancers, clearly, you know, part of preventing this thing will have to be dealing with them. But before we talk about that, Doc, so an average person, what is it that they would notice that would make them suspect that something is not right? And when they go to see a nurse or a doctor, you know, and when they say those things, that would also make the doctor and the nurse to be highly suspicious, you know, that something is not right. So basically the presentation of symptomatology.
Okay, so the precursor lesions, which are those changes you see on the pap smear, an abnormal pap smear will not give a woman symptoms, but cancer will. And also with cancers, very early cancers, your stage 1 cancers will not give you any symptoms because those cancers are still microscopic. Yeah. But for bigger tumors, a patient will have symptoms, and the severity of symptoms will also be related to the grade of the cancer. So for a patient with cervical cancer, they present with abnormal uterine bleeding. So a woman gets their periods, but in between the periods, they have bleeding. And the other thing, because remember I said the cervix is the lowermost part of the uterus. Yes. So the other thing that happens is that they can also present with postcoital bleeding. So a woman has had bleeding after intercourse, yes. Yeah. So because there's a tumor there in the lowermost part of the cervix, which connects the uterus to the vagina. So that is another presenting complaint. And then the other symptom would be a discharge, an offensive watery discharge. And that doesn't usually respond to antibiotics. So you'll find that someone has been going to a clinic and they've been getting antibiotics, but this water doesn't stop. And it's very offensive. And as the cancer progresses, it invades to the nearby structures and to the pelvic side wall, which then that goes to the bones on your pelvis. So once the stage of the cancer is advanced, then you start getting pain, because now as the cancer is advancing, it's infiltrating into the nerves and going to the pelvic side wall. So you can present with pain. And then at a later stage, because of the relationship of the uterus with the other structures, the bladder and the rectum at the back, you could have urinary leakage, but that's already stage 4 disease now. Or you can have fecal leakage through the vagina.
Okay. So that's now worst case situation where it has spread, you know, and has actually caused damage to the neighboring organs. But otherwise, we are saying in the early stages, there may be no symptoms. But once it has progressed, then it may present with symptoms starting within the cervix itself and even extending to the nearby organs. Now, if we look at the risk profile, are there any high risk situations where you say this group of people are actually high risk to get cancer of the cervix? You know, is there a group of people that have got a higher risk than an average person to actually be diagnosed with this kind of infection? Sorry, with this kind of cancer.
Okay. So there are risks. So one of them would be an infection by an HPV virus. So any practice that puts you at risk of HPV, of getting an HPV infection, it will be a risk factor. So multiple sexual partners, having a relationship with a high-risk person, and also any, if you start having sexual intercourse at an early age, and also smoking is also one of the risk factors. And the other risk factors, it includes things like prolonged use of oral contraceptives, and but the main thing, it becomes the sexual practices. And also the number of children that you would have, especially starting early. But you'll find that most of these things, they also connect to the sexual practices. So the main two things actually become your sexual practices and also smoking.
So basically, the earlier you start having sexual intercourse, you say that's a risk factor, right? So those who started early, and then many pregnancies and all of that, but also with smoking. So those are the risk factors that you have pointed out. Lovely. Now, so if then we know that this HPV is one of the biggest drivers of this cancer, what can be done to prevent, that HPV infection? Others, they talk about primary prevention, what can be done to prevent, because if it is the main driver of these cancers, surely if we then prevent people from getting that infection, then we would be making a dent in terms of the, people who subsequently get to have cancers.
So what a person could do to prevent this HPV virus is, change in sexual practices, And the one thing that I also want to mention is that with this virus, once you have it, there is, if you are a healthy individual with a normal immunity, there is a very high chance that your body will clear the virus. And, but then if you have impaired immunity or you are HIV positive, you might not clear the virus. So there is also that, that a person without getting any form of treatment, you can clear the virus. And unfortunately, when we talk treatment, there is no treatment for the virus. Now, if you are unable to clear it, then the persistent infection is going to cause all these problems, but they could be treated at different stages, but we'll talk about that before it actually becomes cancer. So that will be another form of preventing cancer once you've got the HPV, but not that you will get a drug. But what I want to talk about is that the main thing now that we have to prevent this virus is the immunization. But that is for young girls. It has started already in school. I think the program started in 2013. If I'm not mistaken, and young girls at school between the ages of 9 to 13 years. It's a school-based program run by the National Department of Health. So they get a vaccine that will prevent them from getting infected with the two high-risk HPV subtypes, that is 16 and 18. So there is that, and it is a very important thing for, that we have to prevent the virus. And it's also important for us as a community to embrace this, because if we take it on, we are saying in the future, our children will not have this problem that we are facing today of cervical cancer. So that is one way of preventing.
Let me just on that point, was a very, very important point, Doc. The fact that this is one of the cancers that can be prevented if people get vaccination against the germ that's commonly responsible for causing it. Because no other cancer, there are very few others. But this one, how effective are these vaccines?
They are quite effective. In Australia, they started a strict HPV program in 1991, and then in 2007, they started with this HPV vaccine. And initially, they gave it to young girls, and then later it was given to boys as well. And what they have seen is that their incidence, they used to have an incidence of 18 cases per 100,000. And now it has come down to 7 with just these measures. And the other thing is that the vaccine that they used in Australia was the one that prevents 4 types of HPV. 2 of the high-risk HPV and the 2 that causes these genital warts. And the one thing that they've noticed now is that they've actually closed down their genital warts clinic. And it's a thing of the past for them. So that is, everyone in the world uses Australia as a benchmark, because we've seen what has happened in Australia. And now they are having less than 200 cases, 150 deaths from cervical cancer in a year, and we are still sitting with about 3,000 women dying from cervical cancer in South Africa.
Yes. Now, about this program that the government is rolling out, it's for public schools, right? In partnership, obviously, with health. But in South Africa, we are a conservative country. On matters that have to do with sex and sexuality of kids, anything that is in that space, parents tend to be a bit uncomfortable, as if kids get these vaccines or get contraceptives, it's a license that they must go and have sex. So do you know, what the uptake has been of this program? Because I've been trying to follow it, but I have not been able to find whether it is actually doing well or not in terms of uptake. And obviously, it's reliant on the provincial health departments to roll it out in partnership with education. Do you know if it has been successful, or it has made any progress in terms of the rollout? Because obviously, for those who are in the private sector, kids who go to private schools, the parents are expected to be the ones who foot that. So do you know of any, progress around that project?
So for private schools, I'm not sure what is going on, and
it's not there. No, I'm just confirming it is not there. Yes. The parents are expected to foot their pockets because they are thought to have deeper pockets, than the other ones. But just looking at the public health sector one, any updates on how it's doing?
So there is a paper that I came across where they were assessing the progress of this program, and it was published in 2018, I think. And they were saying that they were happy that in those 5 years they had 93% coverage of all the schools that they were aiming to. And amongst that, about 80% of the girls in the appropriate age group were vaccinated. But having said that, when I went to find this information, because I also thought it's something that I do not know, and I was actually thinking it's not going that great, but I was a bit surprised when I found the paper, but it looks like it's running well. And I don't know whether there is anyone who's collecting data for private schools, because I am aware that the parents are sending their children for vaccination, but I don't know if we are all in South Africa. Those are also South Africans. If is there anyone collecting data for those children from private schools and to actually know how well are they doing?
And you mentioned Australia. They extended it to boys because these girls don't have sex alone. They have sex with boys. So it just makes sense that you must cover both boys and girls. But in Australia, I think they also extended it to adolescents, if I'm not mistaken, But for us here, we still need to make sure that we do it so well in the target group of 9 to 13.
Yes.
Right. Yeah. Now, all right, Doc. So that's one way of preventing this cancer, to ensure that our young girls are vaccinated against this germ, HPV.
Yes, that's one part.
Yes. All right. So, okay, Doc. Now let's come back to the Pap smear, situation. Now, remember we're saying prevention. So there's vaccination, but there's also the issue of
secondary prevention with Pap smears.
Secondary prevention, yes. Let's talk about that.
So Pap smears, and also there's also now HPV DNA testing. They form part of secondary prevention. And our guidelines, so in South Africa we have the National Department of Health guidelines, and we also have the HPV Advisory Board recommendations that you'll find that most clinicians are using them. They are different to, especially in private, they are different to the National Department of Health guidelines. But that advisory board is for the Department of Health. So hopefully in the future, we will have our National Department of Health guidelines exactly the same as those HPV guidelines. So the National Department of Health guidelines are saying a woman should start having a Pap smear at the age of 30 years. And we should aim for for 3 pap smears in their lifetime. And that is will then correlate with a 60% reduction in 64% reduction in cervical cancer. But there is also HPV DNA testing.
Yes.
That is also can be done as a core test with the pap smear, or it can be done as a primary screening without the pap smear.
Yeah.
So it's not available in the public sector, but I think the government is in the process of rolling it out. So there are some changes that are being put on the ground to make sure that we will later shift to this HPV DNA testing.
Yeah.
So the HPV Advisory Board advises that a woman should start having their pap smear at earliest at the age of 25 years.
Yeah.
And so the one thing I didn't mention about the National Department of Health guidelines about on pap smears or screening is that for what I said was for HIV negative women. And for HIV positive women, they will have a pap smear yearly. And that has been going on very well. They have their pap smears yearly. Yeah. From the age they test positive and are sexually active. So they'll have their yearly pap smears.
Yeah, okay.
And so going back to the HPV Advisory Board, so you start at the age of 25, and then if you are HIV negative, depending on what you are using for screening, if you are having a pap smear, you will have your pap smears every 3 years. And if you are using HPV DNA testing, it can be done every 5 years. And the HPV DNA testing has become an important thing, especially with the fact that it actually diagnoses whether you do have this virus or not. And it has also helped clinicians to deal with those patients that would have pap smears that are showing minor changes and you're not sure what to do about it. And then you'll add this HPV DNA test. If they are negative, then you know you don't have to worry about that patient. Yeah. But then if they are positive, then you know you need to do more for that patient. So for HIV positive patients, according to the HPV Advisory Board, you also start doing pap smears when they test positive, and they have their pap smears yearly. And if you are using HPV DNA, it can be done every 3 years.
Yeah.
So a woman has to continue with those pap smears if they are HIV negative and with normal pap smears until the age of 65 or until they've had a hysterectomy for whatever reason. And then if they are HIV positive, then they have to continue.
Okay, lovely, lovely. So because we're talking prevention now. So we talked about primary prevention, which is largely around, vaccination for the young kids so that they don't get the germ at all, right? Then we are now talking about early detection, which is we're talking, pap smears, we're talking HPV DNA test as the way to screen people, all right? Now, let's get to any other way of, screening people, besides the pap smear and the DNA test?
So there is another way. It's called VIA. It's performed in a low resource setting or where you are unable to do a pap smear. Yeah. Or also in an area where you think it's your patient will not be able to come back for those results. Yeah. But in South Africa, it is not in the guidelines. So women will still get pap smears. So VIA is a visual inspection of the cervix after applying acetic acid. So you apply acetic acid on the cervix and you have a look with the naked eye.
Yeah.
And there is another triage procedure that we do after someone has had an abnormal pap smear or they are HPV DNA positive, which is called colposcopy, which also uses the same principle as the VIA, but then now you look with the microscope to actually see if are there any changes that suggest that this woman has got yes, these abnormal cells. And so the pap smear and the HPV DNA are actually the screening things that will lead you to, so once you've got an abnormal screen, pap smear or HPV DNA, then you are referred to colposcopy. And then after performing the colposcopy, the patient will receive a treatment, which is then a LETS procedure, where this lower part of the cervix will be cut off. So now going back to what you, I mean, we were coming in a stepwise manner when you were asking how do we treat this HPV or how are the ways of managing. So now the LETS procedure becomes a way of treating these changes in the lower part of the cervix and getting out the part that is susceptible to this HPV virus and AIDS.
Yeah, lovely, lovely. All right, so somebody does the colposcopy and, you know, the acetone or whatever is put there and with the microscope.
Acetic acid, Dr. Fundi.
Yes, I'm sorry, yes, acetic acid.
Acetic acid.
You see, I left school early. But anyway.
I don't want people to be scared that we use acetic acid.
Acetic acid. And so then you look through the microscope, definitely the cells are abnormal. And then what?
So after diagnosing abnormal cells with your colposcope, you can either take a biopsy to actually take a small piece to the lab to confirm that are these abnormal changes really there?
Yeah.
And then if you do that, it means your client needs to come back again for those results of that small piece that you've taken, and then you can do the treatment. Yeah. So, or else you could do colposcopy and you are convinced with what you've found, and you can move straight to treatment. And treatment, the one form of treatment that will be offered is the LETS procedure, which is what when we cut the cervix. But there are other ablative treatments where you use either thermal ablation or cryotherapy to actually burn those, but it doesn't burn to like fire, but you are actually killing those abnormal cells on the cervix, and without cutting the cervix out, which it becomes a better alternative for most for other paid clients.
Yeah. All right. So, but then if you then find that this cancer that you were seeing is actually much more widespread, because I want us to get to the point where we are now starting to think. I mean, it's invasive, you know. Now you need to stage it. So I want you to talk around that, because I want us to get to Dr. Jafta as well.
Okay, so just to try and connect this, if someone presents for a pap smear, they'll either have a normal looking cervix, of which you will go ahead and do a pap smear or HPV DNA testing, or they'll have an abnormal looking cervix where you suspect a cancer already. Then you will take a biopsy, you will not do a pap smear. And then in the group that you've done a pap smear, then you go ahead and do colposcopy and do a LETS procedure. And then after doing the LETS procedure, you can find that in some women, the results come back and saying there is already a small cancer. So most of our stage 1 disease, we diagnose even stage 1B1 and 1B, by 1B2, we diagnose them this way. It's either a woman has had a LETS procedure or a cone biopsy, And then after that, we discover that there's a small cancer on the cervix already. And then in the other group, you can find that already when they're coming to you, there is a macroscopic cancer on the cervix. You can already see a cancer. You take a biopsy to confirm. And then that woman, you will examine her. And in that examination, you are actually staging the cancer. And you might find that there's a cancer that's confined to the cervix, and which is your stage 1 disease. And you can also find that there's a cancer that's already gone to the vagina, your stage 2, and also the tissue around the cervix in stage 2B, your parametria is getting involved. And then with stage 3, then the pelvic side walls are involved, or there are some lymph nodes, of which those ones you can either pick them up on a CT scan, or when you are doing a surgery for the cancer itself. And the different stages are treated differently. Yeah. With the early cancers, stage 1 cancer can be treated by a hysterectomy. And most of the time it will be a simple hysterectomy.
Just for the people who didn't go to medical school, hysterectomy is the removal of the womb, right?
Yes.
Yeah. Okay.
Yes. Yeah. So we remove the womb, and for a stage, some of the stage 1A, 2s, for whatever reasons, but mainly the stage 1B disease, and will need still a removal of the womb. But we're not only taking the womb out, we take the womb out, and the tissue around the womb also needs to come out, because now this is a bigger cancer in dimension. And you want to make sure that when you are taking the womb out, you're not leaving any cancer behind. Yeah. And when you do, that is called a radical hysterectomy. And when you do that, you also take the glands on the pelvis as well. Yeah. There are different groups of glands where the cancer can first spread to, that you will take out during this operation. Yeah. And then stage 2. It's there are some stage 2 cancers that can be treated by surgery, your stage 2A, but it's not universal that they are treated by surgery. So your gynae oncologist will have to make a decision and about whether, if you are in this category, which is the best way for you to be treated. Yeah. Because the one thing about cervical cancer is that the early cervical cancers, as much as you can offer surgery for them, it's been proven that radiotherapy is also equally effective. So, so as much as surgery has got more benefits than radiotherapy, if you can perform it successfully, but the one thing that you'd want to avoid is that you don't want your patient to have surgery and again go for radiotherapy. Although sometimes it does happen that after you've taken the womb out, you realize that there are some areas that need to be treated by radiotherapy. But these patients can also have radiotherapy as a form of treatment.
Okay. All right. Yeah.
So the other thing that also becomes important is that also with your early cervical cancers, your 1A disease and your 1B one, if a woman still wants to have children, there are other ways of other types of surgery that can be performed without removing the womb. Because remember, if you take the womb out, then it means a woman can never have children. But that is also something that will be discussed by the treating gynae-oncologist and the patients.
Yeah.
But for an early stage cancer, we can just take out the mouth of the womb alone that has cancer and leave the womb inside, and then a patient can be able to have a child or two before deciding to have the womb removed.
Yeah. Okay. All right. So now, if obviously you then see that this is stage 3, or maybe let me not preempt this. At what point would you then, refer to a gynae-oncologist or to somebody like Dr. Jafta, who is a radiation oncologist? Yeah.
So in most centers, these women are managed in a multidisciplinary committee set up. So a woman with an early cancer will at some point get to meet Dr. Jafta, even if it's to say, Dr. Ngxola performed the operation and it was successful, there's no need for radiotherapy. But you get, when in that 1B group, you might get tumors that you thought were small enough for you to perform surgery. And then at the operation, you realize that you couldn't get the tumor out completely. Yes. So if there's any suspicion that there's some disease left behind, then she will need post-surgery radiotherapy, of which then that client will be referred to Dr. Jafta. But stage 1B, 3, and 2 going up. Remember the 2, I said it's a very controversial group for sex. So those ones will then be referred to Dr. Jafta because the tumors now are big. And if you see anyone which is stage 3B, you are not going to do anything as a gynecologist or gynae-oncologist. They also need to be treated by a radiation oncologist. But in most centers, as they are seen by the general gynaes or family physicians, they are going to be referred to in an oncology clinic, which has both the gynae-oncologist and the radiation oncologist. And the decision for treatment is taken under one roof. The client doesn't have to see this doctor and then move to the next doctor.
Lovely, lovely. Let's bring in Dr. Jafta now. I think also to give your vocal cords a break, you've been talking for quite some time. Dr. Jafta.
Thank you.
We are now at a point where Dr. Ngxola involves you on a patient that she now has confirmed that this person has got cancer. Now, please, just with your own words, where do you normally come in? And then I want you to take us through now broadly, because there is the chemotherapy, there is the radiotherapy. Earlier you said as a radiation oncologist, I think you guys can do both chemotherapy and radiotherapy. So just tell us usually where do you come in, and enlighten us about what you do when you are either in those multidisciplinary or meetings, and what you do thereafter, especially dealing with those with serious stuff.
Okay, thank you so much. Thanks to my colleague, Ndumi. So what happens is, maybe let me just do a scenario, because we are in a multidisciplinary team. So what happens is the staging is done. We look at the results of that lady with all the history examination. So the gynaes have presented the history of the patient and the results of the surgery, maybe, or maybe before the patient has operated. So if the patient has not operated yet, we discuss the results of the scans and the blood results and anything else that was doing investigation. So as she said, at the earlier stages, they go and operate with all these 1As up to. So we start discussing at 1B1. Sometimes they go like, patient is for surgery, is early stage. However, the patient is not suitable for surgery because, you know, comorbidities, they may be hypertensive, diabetic, although it's early disease, but they can't operate. So we need to offer an alternative that is gonna be equally beneficial for the patient. And those are the things that we discuss. So we end up offering that patients, for instance, early disease, this 1As and that, I will discuss that the type of radiation that we're going to offer. At that early stage, you don't need to do both radiation and chemo. So you end up having an option of giving radiotherapy for that early stage. I will just go into this step by step.
Yes.
Then the type of radiation that is suitable for that 1A, because how we decide which one is suitable or not, with oncology, mainly we're using 2 words, something called progression-free survival, because sometimes you may not eradicate cancer completely. So that is the length of time during and after the treatment of a disease, okay, that the patient lives with that disease. So you are looking at the clinical trials, the new studies, what intervention am I gonna give that proves that there's gonna be longer survival for this patient if I choose this type of intervention. That's what we do. And then you also look at overall survival, the length of time from the date the patient is diagnosed to the day maybe the patient passes on, or the effect of that treatment over a period of 5 years. So you start weighing which trials are saying which intervention is fine. So for those ones that cannot have surgery, when the gynae says this one is a suitable case for surgery, we offer something called a brachytherapy. Now, brachytherapy is a type of radiation. It's a radiotherapy option where now instead of the X-rays coming from the big machine, which is external beam is a linac. The linac that we treat with is huge. So the X-ray, the rays actually come from the machine down to the patient. We say it's external radiation because the source is coming from somewhere. But with the brachytherapy, the source is internal. So we put we have to insert some instruments into the vagina, straight up to the cervix. Sometimes if they've just operated, we put the instruments close to where the edge of where they are cutting is, so that the radiation that we're gonna emit there must be close to where the stump is, you know? So that's where we start, so that we make sure that the radiation is targeted to the area where there's cancer, so that it picks up any cancer cells that are left, any chances that they may be spread. We always make analogy to spinach. You know, when you're growing spinach and you're taking off the leaves, and then you don't take the roots of it. But if you continue to water the spinach, it's actually gonna grow back again, those leaves. So analogy is your estrogen is in the body, you have estrogen circulating. So you have a stump there, you've just had the surgery. But if you run away and you don't come for radiation or anything that you are given to add, because we are trying to make that stump inactive. So if that doesn't happen, because we see a lot of women that had early disease that run away and they think that after surgery, they're not gonna come back. They don't know why they did, because everybody, I mean, she's had surgery. So those are the issues. Now you come, the main stage that the gynaes give immediately to the oncologist is the stage 2. So a problem with stage 2 is that the cancer has moved out of the cervix and it's starting to move to the tissue. As she said, the parametria is the tissue around the cervix. Once it does that, remember there are ligaments there. There's so much blood supply there. So once it touches there are chances now that there is decrease in your overall survival of the 5 years, because you cannot take out you cannot remove the uterus and take out the cancer, because on the side it has already touched the parameter, the tissues. Yeah. So that we look at the option of 5 studies that we looked at that actually proved that with those women that from stage 2 to stage 3 and even early stage 4, after the 5 trials that were made, they were comparing just using radiation, which is external radiation only, and the others were comparing that versus adding chemo with it. So how it works is it's called chemoradiation, that at the same time that the person is getting external radiation to where the cancer was, we are also giving chemo with the drip, because you're trying to sensitize. You want the chemo to work hand in hand with the radiation. So we call it a sensitizer. So they first go for a chemo, and after that they go for radiation, because we want the chemo to sensitize the tumor cells to be more susceptible to being killed, because that's what we are doing. So once we do that, then they go for weekly chemotherapy, and once a week it's chemo, and then the 5 days is radiation. So we found that it's actually better for those kind of stage to prolong their progression-free survival. We're prolonging their overall survival in all, compared to just giving them radiation. Radiation on its own. So, yes, so those that cannot get the type of chemo, because we use a drug called cisplatin, the problem with it is that it has side effects for nephrotoxicity. It kills the kidneys. So when we do like a blood before you start chemo, that's what we're looking for. We're looking whether your bloods are, the kidneys are fine, because eventually you must pass this chemo out. So if your kidneys are struggling, and also problem with ototoxicity, the hearing, sometimes people think that it's them, but you tell them all these side effects before you start. We can change a drug, and eventually if they're struggling a lot, we can even omit it. But you look at the situation at what you're doing. So from stage 2 onwards, this is now mostly the standard of care is chemoradiation, and we're mixing the two together. Then you come to a stage 3. Stage 3, as she said, it has gone to the parametria, but now it has also extended to the pelvic side walls. Now, when it's gone to the pelvic side walls and on the side, it's very difficult to even think about operation. And we get a lot of questions from the women that I want my womb out, and because of what she said when they come, they're presenting with lots of pain that goes around to the back, and they present with lower abdominal pain, and there's PV bleeding, and they just want this uterus out. But by the time you get those things, it is extended to the pelvis. And now what we do is we offer external radiation, and it's a 6 weeks treatment, and still we add the brachy, because we must insert those instruments, because now it's gone to the side wall. We have to make sure that there is internal radiation that actually goes to the side wall. So they go and get we make them lie on the machine as if they are getting X-ray or CT scan, but we immobilize them and make sure that they stay in that position for the next 6 weeks, and treat them so that there's no movement, and treat for 6 weeks. It's daily treatments of about 10 minutes each day, and they finish their 6 weeks. And when they finish their 6 weeks, brachytherapy is once every 2nd week. So they end up having about 4 sessions of brachy in between. So you get somebody who has a full dose of treatment. We are pushing the dose such that there is enough that goes internally as well as externally. By that time, they finish, there's pain is mostly gone in most of them, and the bleeding stopped in week 2. So the other thing we mentioned is that when they start, there are so many side effects that you have to explain, that when you start, your body, you're getting radiation, something comes in, as I mentioned, that it's there to kill the DNA, it's there to kill the cells. So the radiation doesn't know which one is a normal cell and which one is a cancer cell. So you end up damaging the DNA of your normal cell and DNA of the cancer cell. So what happens is there is DNA repair. So the normal cells undergo a process of repairing their damaged DNA, and the cancer cells can't repair. So that's the basis of why. So you are trying to target most of your radiation to a tumor in such that it has 100% killing of that cancer and the recovery of the normal cell. So that's what happens. And then they finish their 6 weeks, as well as the process of chemo does the same analogy, but the issue there is that you are putting a drip and the medication is traveling.
Yeah. So as a radiation oncologist, working obviously with the gynae, you know, you are planning these treatment interventions informed by the staging and many other things, comorbid and whatever. You decide, okay, I'm going to have radiotherapy here. There'll be a bit of brachy. There'll be a bit of external, you know, radiation. I might even need to put some chemo here. But these things are targeting abnormal cells, but they are not discriminate. They are indiscriminate though in how they actually target these cells. So I therefore expect that there would be adverse effects or side effects. So you know, just share some of the common side effects from both radiotherapy, where you are using beams, and also chemotherapy.
Okay, thank you so much. Yes, they are really targeting everything. They can't discriminate. So how we do it is that in the first 2 weeks, we explain the side effects that you're gonna get. Let's start with radiation. We say radiation, the side effects, you're gonna get nausea and vomiting. Some don't actually do. We actually explain why you get those things, because remember, your body wasn't having anything on it. And the vomiting center is activated because of a new treatment that you're putting in. And sometimes because you are treating the cervical cancer, and remember, I'm targeting exactly where the tumor is. So there's gonna be some bleeding in the first few weeks. There's some bleeding coming out of that breaking of that tumor. Because the way anatomically the cervix is, in front it's the bladder and the back is a rectum, like Nondumiso said. So the radiation field is going to have a bit of bladder and a bit of rectum in the field, because you want to get the whole cervix in and the vaginal canal in, because you don't want to miss any area where the cancer might have gone. So you explain that the side effect is the bladder is going to be very irritated. You're going to have like frequency of urination. You must drink a lot of water. You must never be without water in the first few weeks. You must also have, you're going to have diarrhea or loose stools. Don't worry about it, it's going to complete, but if it doesn't, you need to make sure that you alert us. So we check every week, everyone who's on the treatment, whether they've got the symptoms or not. And there can be bladder infection, because remember, others may not drink enough And by the time they go and pass urine, it is a burning kind of urine. So you check out about this. And the skin, remember that the radiation is going to target the tumor is coming from the external beam from a machine. So the first place it's going to hit is the skin. So the skin is going to have some redness, and so I won't go into why and the physics of it. And it's going to have like redness and that, and you can feel that it's warm. It's going to be warm area where we go. So that's why when they mark the radiotherapists, what they do, when they mark the area where they're going to treat, they tell you, please don't wash in the area. Don't wash those marks off, because that's exactly where you're going to be treated for the rest of the 6 weeks. Because the skin is going to thin. And if you wash and start scratching, you may actually peel off that skin. So you want to just tap dry. That's why they can't wait to have a shower after 6 weeks. Patients can't wait to shower when they finish because of that. And they're going to be tired. I mean, lethargy and all that. But all these things happen in the first 2 weeks. And after that, the body regains and they are fine. Some of them, they don't get anything. It only starts after 3 weeks. The late side effects, we say, okay, after a month, when they finish their radiation and post finishing their radiation, they're going to start seeing something from 90 days onwards, and we call them late side effects. The skin, remember, it was red, it wasn't hard at the time. So there's hardening of the skin because of a process of fibrosis that happens. The skin, we can feel where the treatment was. Now, because of the old machines, you could actually see where the person was treated. But now the machines are becoming newer and more sophisticated. You can't actually see that box or block where the patient was treated, because it used to be a very dark area where the person was treated because of the type of the machine and the low energies and all that. But now with the newer machines, you can actually hardly tell where the patient was treated because of that. The skin becomes less tangy and a bit fibrosed. So now, Nondumiso spoke about ovary, issues of fertility. I'm treating the cervix. The ovaries are there. So that's what another thing we speak about with the combined team, that is this a premenopausal person, is a postmenopausal, they still want children and all those things. We don't have the facility of preserving, ovaries and all that in the public sector. But I mean, those that can, they do all preserve their fertility with the ovary, the eggs, because all you know is that it's definitely gonna be in the field, and there's issues of infertility post-treatment. And those are the things that you discuss up front, that issues of that low libido, problems of sexual dysfunction are going to happen post that, because you are actually switching off the ovaries not to produce estrogen.
So now, okay, you wanted to continue?
Okay, sorry. And then because of less estrogen, there'll be vaginal dryness. You're gonna have problems with the swelling of the leg, maybe a left or the right one, because she mentioned that there are lymph nodes involved sometimes. So those are the things that come, and they come up with a big leg, and we look out for a DVT, some clot in that big leg, depending on what is there. They come with long-term bladder infections or what. So the person, before they start radiation, if they are all before stage 4B, we can give. Or 4B, and the problem with that is they sometimes have cancer that has pushed from the vagina straight to the bladder or to the back. So you find that a person is already leaking urine or is leaking feces, and that person cannot be given radiation, because if you give radiation when somebody already has a leak, you are worsening the leak, and you are just opening the fistula, you know, worsening and worsening. So those are the ones that you cannot put, and we start a process of palliation in that kind of a subgroup. But besides that, you mentioned what is going to happen. Chemo is certainly similar, but it depends on the actual drug you are using. The main drug we are using here, mostly for the gynae, in the first one is the cisplatin that I mentioned. It's just those ototoxicity, nephrotoxicity. And problem with the cisplatin is that it stays a lot in the kidney. So you don't want somebody who has poor kidney problems. And you can change it to a less one called carboplat. And sometimes you may not use it at all. But with the newer drugs coming in, because remember I said these are the part of the treatment for cervical cancer, doesn't stop with the chemo or radiation. So now we became cleverer and cleverer and said, okay, now that these two are not discriminating between normal and abnormal, how about we use genes? Because let's do personalized medicine. Let's analyze the type of cancer the person has and the genetic makeup of that cancer, and use that sequence and try and get do a genetic profile for that cancer and get a treatment to treat that abnormality. In that way, that treatment is going straight to the abnormality. It's not going to your normal cells. It's targeting the problem that is there. So we're using those those are new ones.
Is that what we call immunotherapy?
Now, immunotherapy is using your immune system. I mean, basic thing is your immune system comes, your fever, you have fever, it comes in, your antibodies come in, you clear it. So we're trying to see how can we use the immune system to actually fight the cancer. So how it's happening is called now immunotherapy. You know, your innate and immediate. We're trying to play around how the immune system must see cancer, that cancer is a problem, you know. So for that to happen, we need to mark the cancer cell with something so that the body recognizes it as a problem. So the immunotherapy is actually playing against that. But there's a problem with immunotherapy, because if I'm giving you something that's going to stimulate your immune system, your side effects are going to be worsened because your whole body is going to react, because the immune system, that's what it does. So we have a different kind of side effects in the immunotherapy versus that, because the flight and fight, everything with the immunity, you start getting all your flushes and everything else that you were not experiencing. So that is the immune system. But the targeted therapy that I was mentioning, we have drugs like bevacizumab. So we've got a lot of these drugs that have come in, and those are drugs that are actually stopping with the cancer. For the cancer to grow and spread its wings, it actually needs to open up blood supply. It needs, for cancer to grow, it needs a cell that is well nourished with blood supply, okay? So when you kill a cancer, you want enough blood supply circulating there so that you can sensitize, and then it kills. But when you are anemic, you're needing blood transfusion, we can't treat you when you have low blood in your system, because that is not sensitizing the cancer to be treated by radiation. So radiation cannot work when you don't have enough blood supply around that tumor. So what happens is the targeted, the bevacizumab now is trying to intercept that process of the blood supply and trying to block the new blood supply, new blood vessels that are being done by cancer.
The cancer.
And so the bevacizumab, this drug is targeted for that, and it's been proven that it's improving survival. However, prices for these drugs are becoming a problem at the moment, but they have proven that if you can actually add them to your chemo to improve the patient's outcome.
Yes, yes, yes. All right. Now, okay, I think let's try and wrap up now, Zuki. So in a place like Transkei, Eastern Cape, which is largely a low resource environment, the things that we are talking about, I can see them in Johannesburg, I can see them in Cape Town, you know, and maybe Pretoria and Durban, but in the Eastern Cape, largely, how accessible are these things? You know, and also the fact that you're getting people generally quite late, I'm assuming, you know, because of a number of things, you know, late diagnosis, you know, and issues of access to the, I mean, you guys, you are at level 3, you know, what do you call them now, tertiary type of hospitals, you know, or even number, you know. So with all that you've just said, and you know, both yourself and Dr. Ngxola, I just want us to now just reflect on the Eastern Cape and other provinces like Limpopo, like Mpumalanga, you know, how easy is it for you guys to give the best to your patients under such resource constraints? Maybe let me just give you a break and ask Dr. Ngxola, you know, just give your vocal cords a bit of a break as we are wrapping up. So, Dr. Ngxola, you've just moved from Cape Town, which is a place that's relatively well-resourced, to the Eastern Cape, and we know our province has got challenges. Now, how easy is it for you to do your best for your patients under such resource constraints?
So when it comes to gynae oncology, things have changed in the Eastern Cape in the last 4 years, 5 years. There are subspecialists in all the 3 tertiary hospitals. There's one in PE and Dr. Mabenga. Then there's one in East London, Dr. Fekachara, and there's Dr. Gyose in Amtata as well. And I think in PE, they've also started a program of training subspecialists as well. So, I mean, more people are still needed, but at least things are better than what they were before. And when it comes to radiation oncology, PE and East London, they've got radiation oncology departments, and Zuki will talk about Amtata because she's in Amtata now for that. So I think the Eastern Cape government is prioritizing Amtata, which is a very good thing. Remember when I started talking, I was talking about clients would come all the way from Bizana and sleep over multiple times to get to East London. So I think that's one of Zuki's projects, and I mean it's going to come and help a lot of our women, and to also think that that part of the Eastern Cape is actually more populated than the East London and PE side. So it actually makes sense that if we've got any better form of treatment, it should be there. So things are changing slowly, and things are getting better. And I mean, there are challenges that are within institutions, like things like theater time. Now you've got this woman, you are struggling to get to be able to operate on her. But I mean, those are the things that usually can be sorted out within the institution, and I mean the hospital managers are also noticing that there is a need to improve around such things, and also when it comes to cervical cancer prevention. When I left for Cape Town, very few hospitals had colposcopy services in the Eastern Cape. Especially on this where I was working at Frere. Most patients would come from referred from East London, Queenstown for colposcopy Butterworth, Queenstown for colposcopy in East London, and not to mention all the other hospitals that are feeding Butterworth Hospital. But now, in the last few years, they've actually had a program where they were training general practitioners to do, because colposcopy is not a subspecialist service, and they've actually done a great job. So there's also that. So things are changing, and they are getting better.
Yes, lovely. Dr. Zuki, when you now were deployed to go, I'm going to say deployed, from East London to go and make sure that you bring some civilization to my hometown.
Yes.
Tata and the whole 3 million people that Nelson Mandela and Mthatha Central, are servicing. Just tell us, how has it been? I mean, you've been there now since 2017, if I get my facts right, that you were sent there to set up things. How has the journey been?
Oh. Yeah, it's been a challenging one, but I think the main reason for going there, Dr. Ngxola has mentioned, people are traveling 5 days from Lusike to East London.
Yeah.
You get to East London, you are picking up stage 4 cancers.
Yeah.
And they are telling you they didn't know the symptoms, they didn't pick them up, so there were a mixture of patient factors for bringing disease late. There were a mixture of health system factors, our referral system, doing all the problems. So we began to strategize that, daily, if you're receiving 35 bus seater, 2 of them, 2 35-seater buses every single day coming from Mthatha, there is a problem. And they are coming for follow-up, and they are coming for new, and they have been traveling for the past 4 days. So I started going to Mthatha to set up that at least the follow-ups, there must be a unit inside Nelson Mandela. Before that, there were cancer services. 1980-82, there were oncology trained nurses who were giving chemo. So how it would work is we would prescribe a patient chemo in East London, then the patient takes a copy and gives it to the chemo trained nurse in Mthatha General. There was a unit. So people were getting some kind of chemo, but it was not like a fully fledged service. Yeah. So I didn't start from scratch because we had qualified oncology nurses. We just moved the service to Nelson Mandela, but we didn't have like a space. You can't even tell that it's a space. It's like a small passage we're working from. So there were 2 things that are beginning to show. One, there's a great need for the service. We needed to set it up because Nelson Mandela is a teaching academic a hospital that doesn't have a comprehensive service. It services 3.6 million population. It's got 24 referring district hospitals. It's not on that everyone who gets there must be transferred to East London. So that was the main thing behind. And to even make sure that the other specialties, there are subspecialties, there are some disciplines that are developing in there. So there was just like this gap. Having said that, to offer oncology service, a comprehensive one, there's still a huge lack, because the chemo, we are able to get the drugs we are offering. However, we don't have space for inpatient. So you cannot even admit patients for chemo. So the patients for admission, I send to East London. Patients for radiation, I send to East London. Combined clinics in East London. So you're beginning to cut out at least those that are needing chemo only, then you can see and go back. We started with 20 patients a week. We are now at 50 patients a week. We are at 400 patients a month. We are now hitting 700 patients a month. Now, those are patients that are discharged from East London, who are being followed up in Mthatha to be referred back if there's a problem. And those are the patients that have finished radiation. So at least there is some relief of the backlog. But to be complete and offering everything, the main cry we still have is to have a radiation machine.
Yes.
Because then that would make nobody to go.
Yes.
So we've been waiting for the radiation machine. There is a fully
We've been
fledged...
hearing about this radiation machine for years now. I mean, yeah. I've been reading about Mthatha and the radiation machine for the last 3 years. You know, could it not have been prioritized like the PPEs that have been prioritized?
I wish it was a COVID radiation.
Yeah.
It was COVID radiation. Yes, plan. I think a lot of work has been done. The plan is there. There was commitment of the budget, but it has not started since then. The area is identified. It's going to have like inpatient wards. It's going to have an outpatient for children, for adults, and a huge space for that, and also a PET scan machine. Yes. And developing some wards even for the cardiology. So it's a huge plan, and it's very nice. I wish it can be realized, because then the people of that side, of the Transkei, you have a decent place to treat, and you don't have to transfer them anywhere else for care. Yeah. Because even at Frere, they are overloaded. They only have 2 wards with 24 beds, and they have 2 machines. Each machine is treating 50 patients a day. Yeah. And they are on a list, they're on a waiting list. So there is quite a need for a machine. And for Mthatha, we are still going to be...
How much does this machine cost? Do you have an idea, Doc?
Yes, we do know now, because after all these delays, we just said, what is this money? What is this? Well, they're giving us a figure between 35 to 45 million for the machine, depending on what it needs to be. That's
between you delivering quality service, just 40 million.
Yes, and then they need to build a bunker. A bunker is like a whole house with thick walls to house that machine. So you're looking at about another 8 million. So you're looking at 50 million, I would say, to make everyone not go around. You treat everyone in Mthatha. No one is running around going to find radiation somewhere. And then everybody that is treated that side. So what we were supported with, we got a program, we wrote a proposal and got a funder called BMSF. It found Bristol Myers Squibb Foundation that supported the program with 45 million. 45 million was mainly for, 15 million was for community mobilization, because the problem was that people don't know about cancer and they are not picking up the early cases. And then the 23 million was mainly to set up a decentralized center in this way that Mthatha, Nelson Mandela must support 5 sites. So we are supporting Mount Frere, Matzikane, must know how to screen and test cancer and bring people early. St. Patrick's in Bizana is part of it. St. Elizabeth is at Lusikisiki, part of it. We have identified St. Barnabas Hospital.
That's where I was born.
So we want those sites to be equipped with colposcopies, to be able to do what Dr. Ngxola was saying, to pick up the cases, because I need early cases. I need to treat them. I don't want the stage 4s. So I want the gynaes to pick up the early ones, but the early ones are not at Nelson Mandela or at the tertiary, they are out there. So it's important that we improve the awareness, the advocacy, so that people come forward and test and we pick up the early cases. So I can say the journey has been like that. So we renovated a building because we didn't have anything. We renovated a building which is about completion now to actually house an oncology clinic. And at least there will be a place to work from.
That is a Henry Old Hospital?
There's a Henry Old Hospital because there were buildings that were lying vacant and all that. So we say, you know, people, it's not right because we don't have a place to work from. So that has been completed. We're just waiting for furniture and things could be better.
Beautiful.
The machine is still crying.
I used to stay in that the Henry Old Hospital as a student doctor. Remember, I got a bursary from the Transkei government. So we were obliged during holidays to come and do something, you know, assist in the hospital. So they would put us there and, you know, we even worried if there were no ghosts in those places. But anyway, I'm happy that they've found use for those buildings because honestly, it's a big space. And you know, it's good that they've found good use for it. Yeah.
But we're crying for the machine desperately.
Yes, yes.
So what happens is patients that need machine, I then travel to East London to do what I was talking about because you need to draw the volumes and treat them. And then another week, I'm in Mthatha, another 2 weeks, I'm in East London, but I'm tired now. I know every pothole in this.
So how much of help do you guys get from, do you ever get people from Mofrere crossing the Kai River sometimes, besides you coming to assist this site to deal with the volumes about Dr. Ngxola, you know?
I think we haven't got that, but I know Dr. Pockerell used to travel to Mthatha to do the combined clinics with the team even before all days when the chemo sisters were running. He also stopped because of the traveling up and down and those kind of things. It's not safe at all. And I was saying the day they decide on the radiation machine, will get the best that this team in East London is aspiring to. Maybe they are going to cross the Kai River and go to the best machine that side.
And she will have qualified as a gynae oncologist.
She will definitely walk with me. So it's important though to improve the service at every point because I know it's been happening for long. It doesn't mean it's right that this traveling is happening.
So I think a lot of lobbying needs to take place, you know, at the right levels, because I mean, it really does not make sense. If you've got a population of about 6 million being in the Eastern Cape and 3.6 million are dependent on that Nelson Mandela Academic Hospital, and yet the other population of 2.4 million or so already has got 2 facilities. And this side, I mean, that's inequity, you know, in terms of resource allocation. It just does not make sense. It's part of the legacy of our, you know, homeland and Republic of South Africa situation. And it can't be allowed to continue 26 years after, you know, the new South Africa. So I think people at the right places need to actually make the right decisions. But lobbying, you know, is one of those. I mean, if they were able to mobilize monies for PPEs, even giving people who've never even got into the space of healthcare, you know, they were into catering and whatever, but they got big contracts. I think this is a worthy, you know, investment for the lives of the people of that part of the world. So, but hang in there. I'm sure things are going to get better. hang in there. And at least the N2 is much better now. The road is much more broader, but then there's nothing you can do about the animals and the tractors that don't have reflectors that also drive on those roads. So, but looking at cancer of the cervix and other, cancer of the cervix in the Eastern Cape, Dr. Ngxola, do you think there's light at the end of the tunnel? People are going to be able to be diagnosed earlier and get appropriate interventions earlier. And your closing remarks, and I'll just do the same with Dr. Jafta.
Okay, thank you.
I want to leave people with an element of hope and not get a sense that it's all doom and gloom.
Thank you, Dr. Fundi. So as I had said that in the Eastern Cape now, we do have gynae-oncologists. And we also have the district services that have come on board on this side by initiating colposcopy services in the districts that are now running smoothly. So Dr. Mandondo, actually, that was her project. And so I think now that we've got all these hospitals with gynae-oncologists, there are programs that are going to come out of the Eastern Cape that are actually going to be of benefit to the people of the Eastern Cape. There is research that is coming up in the Eastern Cape around cervical screening programs. So I think things are going to get better. In fact, you can't ask me about things getting better. I'm such an optimist. I won't stop talking. So I know for sure that things are going to get better. So in closing, I just want to say thank you for the opportunity, and I hope people at home have learned something from the talk. And if there are any questions, they can visit their gynaes and have discussions around this topic. And the important thing that cannot be overemphasized is that if your child comes back from school with a consent form for HPV vaccination, please do sign it. You only have this opportunity now to make sure that she or he doesn't get cancer later on in life. And I mean, if there's one thing that any parent can do is to make sure that their children are vaccinated according to for any condition that can be a threat to their lives in the future. Yeah. And I mean, I know there are a lot of groups that are against vaccination, but if a person has got questions, it's one of those things that Dr. Google is not going to help you about. Go to your gynae, find out exactly why must you do this. Yeah. And I mean, the vaccine itself doesn't contain any viral particles. So other people will always worry when you talk about vaccination, are they not giving me the virus? Yeah. So go to your gynae, go to your family doctor and just ask, and yes, that's all. And then for all women above the age of 25 years should start doing pap smears and also
HIV positive, they obviously
and if you're HIV positive every year and you follow up on your pap smear, you don't just do a pap smear and not go and collect results. That is another problem. I mean, in the first world, people are called in for their pap smears and they're called in for results. We don't have such a service, and this is probably also why our screening program has not helped us that much, because in other countries, they did manage, even before vaccination, to have some improvements in their incidences just from the screening, but our screening is then relying on the patient.
Yeah.
So for those that are listening, go get your pap smear, go get the results, find out what does the result mean. And if you are referred to the next clinic, go to the next clinic and ask questions. You don't have to accept all the treatment that you are getting, but you must be clear on what you are being offered. And yes, with that, thank you.
Enkosi kakhulu, Dr. Ndumi. Looking forward to talking to you and to say, I am now a fully fledged gynae oncologist. You know, so, but I'm sure between now and then, there may be an opportunity to talk to you again, because, you know, it's important that we highlight some of these health challenges from an access point of view. And I'm happy that people like you are able to come back from the Western Cape and actually make a difference, you know, at a local level. So thank you very much. Thank you. Dr. Jafta?
Yes, thank you. I think I just have a few pointers. One, messages I want to get out is that this talk has highlighted a few things. One, that cervical cancer is a leading cause of mortality.
Yes.
In Africa. And you also pointed out in another discussion that Eastern Cape has an incidence that is actually higher than the average in South Africa, which is a problem. And 90% of the cases that we are discussing about are caused by HPV. Dr. Ngxola has explained how we eradicate it. And I hope people have taken that point, because HPV causes 90% of the problem. The government has led the way, has prioritized cervical cancer. It's one of the cancers that are national priority, secondary to breast, has got a cervical cancer policy, has got the cervical cancer guidelines that tell you what to do. People that are in the institutions can download the policy and the provincial guidelines, because they talk to the primary and secondary prevention. To that, when people now get access to treatment, we are requesting that comprehensive cancer management. Cancer has come in a very drastic way with so many cancer mortality cases. I don't think we are there yet in trying to take the challenge head on, because the poor resources that are scattered, I think there can be a way of rearranging and correcting the unequal distribution of resources. Because it's going to continue to cause the increasing problems and the mortality we're trying to talk about. It's frustrating as specialists in the fields when you know what you're supposed to do, but you don't have the tools to use to do exactly what you need to do. And the people are thinking of you as a sign for relief or a sign for cure or whatever, and you also are incapable because of the tools that you don't have to use. So you lead to frustration because you don't have the means to do what's right. And why do we have to leave the province to go to other provinces just because there is a LINAC in Joburg, there's a LINAC in Durban, there is a LINAC in Port Alfred, and where there is no LINAC, there is actual dates that they know that they are getting the LINACs. And I think it's a very, it's a point, I'm not sure for people that are up there to take up and put like big glasses on it, because it's not only stifling the kind of services that the hospital is supposed to have, it's actually affecting the whole 3 million population. Just to know that when I'm diagnosed with cancer, it's actually a death sentence, because I'm not gonna get the treatment in the hospital. I travel long distances for care. So it does have negative implications. It makes our our education, screening efforts, everything futile because they ask you, and then what? You diagnose me with cancer in early stage, and then what? Because the system makes them wait until they are advanced, and which is something that we're trying to reverse. But you can only do so much. And people will always say why people are leaving the center, the public sectors, why are you going to other areas and not serve the province? It's been 3 years. We're waiting for a machine. It's coming. It hasn't come. And the people need the service. They've been needing the service.
Yeah.
And I think for the, I don't know what else can make the point stronger, that there is a need. I'm not sure whether the need is not seen, because highlighted everything that the need is seen, but akwenzeki, you know.
I think
nobody says no,
yes.
but there's a weight.
Yes.
That
no, I think that's why I said earlier, the issue of lobbying that legislature in Bisho, especially the portfolio committee on health. The portfolio committee on health in Bisho needs to be lobbied and be presented with the facts, and civil society has to also put pressure, to make sure that the people are heard. So I think sometimes it takes those kind of actions to get people to actually take the right decisions. So, but hang in there. We'll see. We'll see. Where one has got buttons to press, one will press, because it is unacceptable. It would be a sad day that talented people, very skilled people like you are, who've committed to making a difference, actually now, that you get to a point where you give up and then you migrate like everybody else to major urban centers, because that will be a loss for the province. So I think the window period for this to be done, it cannot be infinite. There needs to be commitments to say within the next 12 months, in the next budgetary cycle, we will make sure that this thing is, is actually budgeted for. But you can't just be kept in limbo and be, waiting and waiting, and people are dying in the process, because it's killing your morale, because what should be done for those people who deserve care. I mean, we are in the same country. There's supposed to be equity of access to healthcare. It's one, the right to health is actually, enshrined in our constitution. So you can't have that right being, a reality for people in other parts of the country. But then you've got 3.6 million people, or 6 million in the rest of the province who actually have got, they're more like second-class citizens. So it's unacceptable. But I think let's hope that with the right noises at the right places, this thing is going to change. 50 million is not a lot of money to actually save the lives that you guys are supposed to be saving. So with those words, I want to thank you, both you, Dr. Nondumiso Ngxola, and also Dr. Zuki. So, it rhymes, Ndumi and Zuki, Thank you very much, man. I took so much of your time on a Saturday afternoon, which is a family time. You're supposed to be spending this time with your families, because during the week, it's normally very hectic. So I want you to, I just want to thank you for being generous with your time. I've just heard that this recording did not go through with all the lines where we're supposed to broadcast. So we are going to harvest it and also put it again on YouTube, on Facebook, and I'll also send it to you hopefully by this time tomorrow, so that you can be able then to share with those people who were not able to have access to it. But thank you very much, and thank you to those who joined us. I can see Xolisa. By the way, Xolisa Mweran, sent me a message on Facebook. I'm not sure if it's him, but it's a Mweran who's my Facebook friend. Maybe it's not him, but somebody said, no. This is one person that you must also interview in the near future, because she's just doing too many things. So, and this morning I saw a message that says, now I know that she's going to be appearing on your thing at 4 o'clock. So thank you for listening. So, so okay, but anyway, I will be reloading this video of about 2 hours, and I will send it to each one of you so that you can disseminate. But thank you very much for your time.
Thanks so much. Thank you.
All right. Thank you.
Bye.
Thank you, Dr. Ndumi.